Welcome back to Beyond the Stethoscope, the podcast for general practitioners.
Great to be here.
For this deep dive, we're focusing squarely on something critical for you busy GPs, and especially those of you preparing for fellowship exams. We're talking osteoporosis.
That's right. We're diving into Chapter 81, Osteoporosis, from the classic Murtaugh's General Practice, 8th edition. And the goal isn't just a quick summary. We want to really unpack the key concepts, the different classifications, how to investigate effectively, and, the management strategies.
Really solidify that knowledge.
Exactly. Make it practical, make it stick.
So why is this so important right now? Well, osteoporosis, it's sneaky.
It really is. It's silent, very common.
But the good news is it's measurable, it's treatable.
And we have to remember, it can be potentially lethal if we don't manage it properly. The consequences of fractures can be severe.
You're seeing patients at risk every single day, aren't you? Especially postmenopausal women, older adults generally.
Absolutely. So understanding the details, the nuances, it's crucial for picking it up early, managing it well.
And ultimately preventing those really significant problems for patients. Plus, nailing this is key for your exams.
Definitely.
So over the next hour or so, we'll dig into the pathophysiology, what's actually happening to the bone, explore the different types, walk through the diagnostic process, and detail the current treatment advice, all tailored for general practice.
And we'll keep an eye on those implicit index cases Murtaugh presents through the classifications and risk factors, those little patient snapshots.
Perfect. Okay, let's start at the beginning. What exactly is osteoporosis? Murtaugh says porous bone, literally.
Yeah, porous bone. And physiologically, it means you've got reduced bone mass per unit volume.
So less bone packed into the same space.
Exactly. Think of it like scaffolding that's become thinner and has bigger gaps. The whole structure is weaker, more fragile.
Making it much easier to fracture.
Precisely. And Murtaugh really highlights that accelerated bone loss in women after menopause. That drop in estrogen is a huge factor.
Which directly links to why we see higher fracture rates in women, doesn't it?
It does. By age 65, the fracture rates are, maybe 3 to 5 times higher in women compared to men.
But it's crucial we don't forget men.
Absolutely not. Men account for about 1/3 of all hip fractures. It's a significant issue for them, too.
Murtaugh touches on the history a bit with HRT. Our approach has shifted, hasn't it?
Yeah, it really has. HRT was sort of the go-to prevention for a while, targeting that estrogen loss. But then concerns emerged about long-term use and breast cancer risk.
So now the focus is broader.
Right. We have more strategies, more options now, which reflects how, medical understanding evolves.
Which brings us back to those key words Murtaugh uses. Silent, common, measurable, treatable, and potentially lethal. Let's just pause on those. Silent.
Crucial point. Often no symptoms until, bang, a fracture happens.
Common. The stats are pretty stark.
Yeah. Lifetime risks. Something like 2 in 5 women, 1 in 4 men will have a fragility fracture. And for a woman reaching 90, the hip fracture risk is maybe around 30%. Huge.
Wow. Measurable. That's where DEXA scans come in.
Exactly. We can get objective numbers, quantify that risk.
Treatable. Lifestyle medications. We'll get into those.
Yep. And potentially lethal just reminds us of the serious downstream effects, especially with hip fractures, disability, loss of independence, increased mortality.
It's also key to tell patients, isn't it, that the pain they feel is usually the fracture, not the osteoporosis itself.
Absolutely. They might have no idea until a minor fall causes, say, a collis fracture.
Wrist fracture.
Yeah, or a hip fracture.
Right.
Or they suddenly get back pain from a vertebral fracture, or just notice they're getting shorter.
And Murtaugh flags vertebral collapse as a real hallmark sign.
Yes. If you see vertebral compression fractures, especially without major trauma, you have to suspect osteoporosis.
But
Crucially, you also need to think about other causes in that situation, especially multiple myeloma. Got to rule that out with vertebral osteoporosis or any pathological fracture.
Okay. Before we dive into the types, what's the baseline advice? Initial prevention.
The foundations are regular weight-bearing exercise, making sure dietary calcium intake is adequate. Murtaugh mentions 1,500 milligram initially. We'll refine that figure shortly. And keeping vitamin D levels sufficient. Those are the cornerstones.
Right. Let's get into the classifications then. Murtaugh divides it into primary and secondary. Let's start with primary.
Okay, so primary means the bone loss isn't directly caused by another illness or medication. It's got 3 subtypes. Type 1 is postmenopausal.
This is the classic picture for many, I suppose. What defines it?
Typically, you see fractures in the vertebrae or the distal forearm, that collis fracture again.
Right.
Age range is usually 51 to 75 years, postmenopause.
And the mechanism.
It's mainly increased osteoclast activity. Those are the cells that break down bone, so resorption ramps up.
Makes sense with the estrogen drop.
Exactly. And at Murtaugh notes, it's about 6 times more common in women than men in this group. So that index case. Think a 62-year-old woman, minor stumble, presents with sudden back pain, turns out to be a vertebral compression fracture. Classic type 1.
Got it. What about type 2 primary?
Type 2 is often called involutional or senile osteoporosis.
Okay.
Here, the typical fracture sites are the proximal femur, the hip, and other bones too. It affects older people, generally over 60.
And the pathophysiology, is it different?
It's a bit more complex, related more generally to aging. You get a gradual decline in the activity of osteoblasts, the bone-building cells, while the osteoclasts keep doing their thing.
So less building, ongoing breakdown.
Sort of, yeah. And in this older group, things like reduced vitamin D production in the skin and maybe less efficient absorption also play a role.
And the gender split.
Still more common in women, but the ratio is closer, maybe 2 to 1. So the index case here might be an 80-year-old who falls at home and sustains a hip fracture. That screams type 2.
Okay. And the third primary type, idiopathic.
Yeah, idiopathic. Less common and a bit mysterious. It happens in children and young adults, both sexes, and crucially, they have normal gonadal function, normal hormones.
So we just don't know why.
Pretty much. The cause is unknown. The index case might be a perfectly healthy 25-year-old man who has a DEXA for some unrelated reason and gets a surprisingly low reading. Needs careful workup to exclude everything else.
Right. That leads us nicely into secondary osteoporosis.
Yeah.
This is where something else is driving the bone loss.
Exactly. An underlying medical condition or maybe a medication. And Murtaugh's table 81.1 here is just gold for clinical practice. It lays out all the risk factors and causes.
It's incredibly useful. We should probably walk through it thinking about those index cases, the typical patients we see.
Definitely. The table groups them nicely. First, constitutional and non-modifiable factors, things you can't change.
Like
Female sex, obviously. Advancing age, Murtaugh specifies over 60 for men, over 50 for women. He also includes sarcopenia.
the age-related muscle loss.
Yeah, which often goes hand in hand with bone loss and ups the risk of falls. Then there's having a thin build, low BMI, under 20, short stature. Race plays a part too. Asian and Caucasian populations tend to have higher risk.
And family history,
Oh.
always important.
Very, especially maternal hip fracture before age 75, that's a strong signal. Also, factors related to lifetime estrogen exposure, premenopausal estrogen deficiency.
Like prolonged amenorrhea.
Exactly. Think of that index case. A young female elite athlete, intense training, low body weight, stopped having periods. That's a red flag for bone health. Late menarche, early menopause, before 45 natural or surgical also fall into this category.
Okay, those are the non-modifiable ones. What about modifiable lifestyle factors? Where can we actually intervene?
This is key for prevention. Cigarette smoking, direct toxic effect on bone cells. High alcohol intake, Murtaugh defines it as more than 2 standard drinks a day, interferes with calcium absorption, bone formation. Low dietary calcium intake, lack of vitamin D, and physical inactivity, not enough mechanical stress on the bones. All areas for counseling.
Then there's the long list of medical causes. Need a good history here.
Absolutely. Eating disorders like anorexia nervosa, devastating effects, especially in young people, due to malnutrition, hormone disruption. Another clear index case.
Right.
Malabsorption syndromes, coeliac disease, inflammatory bowel disease impairing nutrient uptake.
Calcium, vitamin D.
Precisely. And then a whole raft of endocrine disorders, Cushing syndrome, that excess cortisol hammers bones, diabetes, both type 1 and 2, hyperparathyroidism, putting calcium out of bones, thyrotoxicosis, accelerating bone turnover.
You mentioned amenorrhea in athletes again.
Yes, fits here too. Hypogonadism, low sex hormones in either sex. Even acromegaly can affect bone.
It's a huge range of endocrine conditions.
It really highlights how hormones regulate bone. Then you've got connective tissue disorders like rheumatoid arthritis, chronic inflammation is bad news for bones. And chronic organ failure, kidney, liver, heart, lungs, they all have downstream effects on bone metabolism, vitamin D activation. So think about your patient with long-standing RA or someone with chronic kidney disease. They need careful bone health monitoring. Those are important index cases.
Definitely. And finally, the drugs that cause bone loss. We prescribe these all the time.
This is critical for medication reviews. Corticosteroids are the big one. More than 3 months at 7.5 milligram prednisone equivalent or more daily. Classic cause.
So are COPD or asthma patients on long-term steroids?
High risk. Index case right there. Also, some anti-epileptic drugs, especially the older enzyme-inducing ones. Proton pump inhibitors, long-term use link seems to be impaired calcium absorption, maybe.
Interesting.
Thiazolidinediones for diabetes. Long-term heparin, getting too much thyroid hormone replacement. And the hormone therapies for prostate and breast cancer.
Yeah.
And don't forget prolonged immobilization. Someone laid up after major surgery or injury, bone loss happens fast. Another index case.
That table is just indispensable, isn't it? Really drives home the need for thorough history taking, including medications.
Absolutely. Identifying and managing these secondary causes is fundamental.
Okay, great. Let's shift gears to investigations. We suspect osteoporosis, maybe based on risk factors or a fracture. How do we diagnose it?
Well, the first thing people think of is an X-ray, maybe.
Yeah.
But plain radiography is actually quite limited for early diagnosis. You need to lose a fair bit of bone, maybe 30–40%, before it's obvious on X-ray.
So it's good for seeing fractures.
Essential for that, yes. But a normal X-ray doesn't rule out osteoporosis.
Okay, so what else? Blood tests.
Yes, initial bloods are really important, mainly to look for those secondary causes we just talked about.
Right.
So definitely check a 25-hydroxy vitamin D level, aiming for that optimal range, 75 to 250 nanomoles per liter. Also check serum calcium, phosphate, alkaline phosphatase, and parathyroid hormone.
And what do we expect to see in primary osteoporosis?
Usually they're all normal. Calcium, phosphate, ALP, PTH, typically normal in primary type 1 and type 2.
Okay. Anything else?
Thyroid-stimulating hormone, TSH, is important. And like we said, if you're seeing vertebral osteoporosis or a pathological fracture, think about tests for multiple myeloma, serum protein, electrophoresis, urine, Bence-Jones protein.
Got it. But the real key investigation is
The DEXA scan, dual energy X-ray absorptiometry. That's the gold standard.
for diagnosis and predicting risk.
Exactly. It measures bone mineral density, BMD, usually at the lumbar spine and the femoral neck.
Which site is most useful?
The femoral neck BMD is generally considered the best predictor of hip fracture risk.
And it gives us a number in grams per square centimeter.
Correct. Lower BMD equals higher fracture risk.
Yeah.
Simple as that.
This is where T-scores and Z-scores come in. Can you break those down for us? They can be a bit confusing.
Yeah, they can. So the T-score compares your patient's BMD to the average BMD of a healthy young adult, specifically a 30-year-old of the same sex.
Okay.
It's expressed in standard deviations, SDs. How far above or below that young adult mean are they?
And the cutoffs.
Osteopenia, which is low bone mass but not quite osteoporosis, is a T-score between -1 and -2.5 SDs.
Go ahead.
Osteoporosis itself is diagnosed when the T-score is -2.5 SDs or lower. So -2.5, -2.8, -3.0, that's osteoporosis.
And severe osteoporosis.
That's a T-score below -2.5, plus the patient has already had one or more fragility fractures. And generally, a T-score of -2.5 or less is where we start thinking seriously about pharmacological treatment.
Right. So what's the Z-score then?
The Z-score provides a different comparison. It compares the patient's BMD to the average BMD for people of the same age, sex, and ethnicity.
Ah, okay. Age matched.
Exactly. So it's most useful for people under 50, premenopausal women, younger men, and children.
Why is it better for them?
Because a significantly low Z-score, say less than -2, suggests their bone density is much lower than expected for their age group. That really flags the need to hunt aggressively for an underlying secondary cause.
So T-score for overall risk assessment relative to peak bone mass. Z-score for flagging potential underlying problems in younger people.
That's a good way to put it, yeah.
It's also really helpful knowing the MBS criteria for getting a subsidized DSA.
Absolutely. So it's subsidized for everyone over 70. The frequency of follow-up scans, maybe 2 or 5 years, depends on that initial T-score.
Okay.
Also covered after a low-impact fracture for diagnosis. And for screening people with specific conditions or on specific meds known to cause osteoporosis, often annually then. And for monitoring people with low BMI, usually every 1 or 2 years.
Good to know. And if someone doesn't meet the criteria or we want an absolute risk score, the FRAX tool.
Yeah, the FRAX tool can be useful there. It estimates the 10-year probability of a major osteoporotic fracture, hip, spine, forearm, shoulder, and also hip fracture specifically. It uses risk factors and can incorporate BMD if you have it.
But Murtaugh adds a slight caution.
He does, mentioning its development involved funding from drug companies. So use it as part of the picture, but perhaps with a critical eye. Don't rely on it solely.
Okay, that makes sense. Right, we've defined it, classified it, investigated it. Let's move to management.
Okay, so if someone's had a fracture, the immediate priorities are managing pain, getting them mobile again, and critically, putting falls prevention strategies in place. Murtaugh points us to chapter 125 for falls.
It's a whole package, isn't it?
Absolutely. Alongside that, you've got to identify and treat any underlying secondary causes and do that medication review. Can we deprescribe anything that's increasing risk of bone loss or falls?
So it's not just about jumping to medication.
Not at all. But drug treatment is, of course, a major part. The goal is to prevent further bone loss or slow it down and reduce fracture risk. As Murtaugh notes, current treatments don't really replace bone that's already lost.
Right. What about the specific drug recommendations? The American College of Physicians guidelines are mentioned.
Yes, the ACP guidelines are quite practical for us. They recommend treating women with known osteoporosis with drugs like alendronate, risdronate, zoledronic acid, or denosumab. These have shown benefit in reducing both hip and vertebral fractures.
And for how long?
They suggest 5 years for the oral bisphosphonates or 3 years for the annual IV zoledronic acid. After that, treatment can often be stopped unless perhaps they've had a very recent fracture.
It's interesting, a drug holiday concept.
Sort of, yeah. They also specifically advise against using menopausal hormone therapy, MHT, just for treating osteoporosis.
Okay.
And another practical point, they suggest routine BMD monitoring during that 5-year treatment period might not be necessary if the patient is responding, because fracture risk reduction seems to happen somewhat independently of BMD changes in many cases.
Good to know. Saves unnecessary tests. What about men?
Offer bisphosphonates to men with clinically recognized osteoporosis. And for older women, say over 65, who have osteopenia but are at high fracture risk according to FREX or other factors,
Yes.
the decision to treat should be really individualized. Talk to the patient about their preferences, the risks, benefits, costs. It's shared decision-making.
Makes sense. And they flag a specific risk with denosumab.
Yes, potential for hypocalcemia, low calcium levels, which rarely could lead to issues like heart failure. So, need to monitor calcium.
Okay. Murtaugh then lists the main medication classes. Let's run through those.
Sure. HRT-MHT, we've mentioned its limited role now primarily for osteoporosis. Then the workhorses, the bisphosphonates.
How do they work again?
They inhibit the osteoclasts, the bone-resorbing cells, so they decrease bone breakdown.
Examples.
Oral options are alendronate, usually 70 milligrams once weekly, needs to be taken on an empty stomach, upright, lots of water because of the risk of esophagitis.
Right.
Risdronate is another oral one, 150 milligrams once monthly or 35 milligrams weekly, sometimes combined with calcium and vitamin D.
And the IV option?
Zoledronic acid, that's a once-yearly infusion, convenient for some patients.
Downsides to bisphosphonates.
Esophagitis with the oral ones, as mentioned. And the rare but serious risk of osteonecrosis of the jaw, ONJ, particularly with longer-term use or higher doses, often used in cancer. And atypical femoral fractures, also rare.
Okay. What else is there beyond bisphosphonates?
Raloxifene. It's a SERM selective estrogen receptor modulator. Acts like estrogen on bone. Given orally, daily, mainly reduces vertebral fracture risk.
Yeah.
Then there's teriparatide. This one's different. It's a synthetic form of parathyroid hormone.
And it builds bone.
Yes, it actually stimulates osteoblasts, increases bone formation. It's usually second line, given as a daily subcutaneous injection for a limited time.
Right. And denosumab.
That's a monoclonal antibody targeting rank ligand, which is crucial for osteoclast formation and survival. Very effective at reducing resorption. It's a subcutaneous injection every 6 months.
Considerations with denosumab.
Need to ensure calcium and vitamin D levels are adequate before starting and during treatment. And again, that potential, though small, risk of ONJ may be slightly higher than with oral bisphosphonates, especially in cancer patients. Also, rapid bone loss can occur if it's stopped abruptly, so need a plan for follow-on therapy.
So choosing between these, it's complex.
It really depends on the patient's profile, age, severity, fracture history, kidney function, potential side effects, patient preference, cost. Lots to weigh up.
Okay, let's circle back to prevention. The lifestyle stuff is absolutely vital.
Foundational. Stop smoking. Limit caffeine and alcohol. Murtaugh says 2 standard drinks or less per day. Maintain a healthy weight, good nutrition. Aim for that BMI of 18-25.
And calcium and vitamin D. Let's clarify those calcium numbers again.
Right. So for women under 50 and men under 70, aim for at least 1,000 milligrams of elemental calcium per day.
Okay.
For women over 50, men over 70, and anyone on osteoporosis therapy, the target goes up to 1,300 milligrams per day.
Best from diet.
Ideally, yes. Dairy, fortified foods, leafy greens. Murtaugh has a list. But if dietary intake isn't enough, especially in postmenopausal women, supplements are needed.
Citrate versus carbonate.
Calcium citrate is often better absorbed, especially if someone has low stomach acid or is on PPIs. Carbonate is cheaper, has more elemental calcium per tablet generally, but needs to be taken with food for best absorption.
Good practical tips, and vitamin D.
Crucial for calcium absorption. Needs sensible sun exposure, face, arms, hands, but balancing that with skin cancer risk obviously depends on location, time of year, skin type.
So checking levels is important.
Yes, measure serum 25-hydroxyvitamin D. Aim for above 50 nanomoles per liter as a minimum, ideally higher, maybe 75 or more.
And deficiency levels.
Mild is 30-49, moderate 12.5 2-tine, severe below 12.5. If levels are low, supplementation with cholecalciferol vitamin D3 is needed. Usually 1,000 to 2,000 IU daily, sometimes higher doses initially for deficiency.
Okay. What about exercise?
Moderate weight-bearing exercise is key. Things like brisk walking, maybe 30 minutes 4 times a week, jogging, dancing, tennis. These higher impact activities are probably even better for stimulating bone if appropriate for the patient.
And reduces falls risk too.
Exactly. Improves strength, balance, coordination. That links back to the falls prevention strategies in Chapter 125. Hip protectors get a mention, but evidence is a bit weak, and people often don't like wearing them.
Right. Murtaugh briefly touches on natural remedies.
Yeah, an Australian review confirmed good evidence for exercise improving BMD in postmenopausal women,
Okay.
but little good quality evidence for things like natural progesterone cream. Insufficient evidence for boron, cod liver oil, or fancy chelated calcium supplements over standard calcium carbonate.
So stick to the evidence-based stuff.
Pretty much. Complex mineral formulas often don't add much and might even have less calcium.
How do we monitor treatment effectiveness?
Generally, repeat a DEXA scan about 2 years after starting therapy to see the response.
Yep.
Maybe sooner, every 1 to 2 years, if there's been a significant change in treatment, or if they're at very high risk of ongoing loss, like long-term steroid users or post-transplant. But remember the ACP guideline nuance about routine monitoring within the first 5 years, potentially not always being necessary if responding clinically.
Got it. We should also remember osteoporosis in children and adolescents.
Yes, important though, less common. It's usually secondary osteoporosis in kids, often linked to chronic inflammatory diseases needing steroids or things causing immobility.
Other causes.
Malignancy, malabsorption like cystic fibrosis, poor nutrition, anorexia, hypogonadism, and the rare primary cause is osteogenesis imperfecta,
And assessment.
DEXA, but interpret using Z-scores, not T-scores. Management is specialized, definitely needs referral, may involve bisphosphonates.
And osteoporosis in men. Murtaugh points to another chapter.
That's right. Chapter 102 covers it in more detail, focusing on the specific causes and risk factors often seen in men, like hypogonadism or alcohol excess.
Finally, when should we definitely refer?
Refer children and young adults. Consider referral for postmenopausal women or older men if their case is complex comorbidities, diagnostic uncertainty, poor response to treatment. Also refer if it's secondary osteoporosis due to a complex underlying illness that needs specialist input, or if you need advice on managing difficult pathological fractures or significant height loss.
Great. Okay, let's try and pull the key threads together. We've gone through the definition porous bone, fragility risk, classification primary types, postmenopausal, senile, idiopathic, and the huge range of secondary causes from Table 81.1, highlighting those index cases.
Yep. We covered investigations, the limits of X-ray, the importance of bloods for secondary causes, and DEXA as the gold standard with T and Z scores.
And the multifaceted management lifestyle is foundational. Calcium, Vit D, exercise, falls prevention, addressing secondary causes, deprescribing, and then the pharmacological options like bisphosphonates, ditosumab, teriparatide, raloxifene, guided by ACP recommendations and individual patient factors.
So thinking about your exams in your day-to-day practice. When a patient comes in after a fall and fracture or with multiple risk factors, how will you approach it? How will you classify? What tests? Which treatment makes sense for this patient?
This deep dive into Murtaugh Chapter 81 is hopefully a solid base, but definitely go back to the chapter, check out reference guidelines like NICE, maybe look critically at tools like FRAX.
Remember, osteoporosis is often silent until that fracture happens. Your proactive approach, identifying risk, investigating appropriately, implementing evidence-based prevention and treatment makes a massive difference to your patients' lives, reducing their risk of those debilitating fractures.
And the final thought, what other silent conditions might be lurking in your patient population? How can you proactively screen for or manage those?
Good question to ponder.
Thank you for joining us on Beyond the Stethoscope. Until our next deep dive, keep exploring and keep learning.
Keep up the great work out there.